Morning. I want to make this lecture somewhat interactive, somewhat demonstrational, and hopefully somewhat memorable, because I know you're not on rotations yet. And being an obstetrician gynecologist, there have been times there were students on my service who would make remarks in front of the patients like, "I've never seen that before," or "You do it like what?" So we'll address all that today. I thought this was the most osteopathic OB/GYN picture I could find. Because osteopathically speaking, here's what I wanted you to appreciate. Well, I try to appreciate this. Oh, here we go. Now, when we look at people and they look like this, all right, thank you, and we say, wow, you need a treatment or a series of treatment, I want to tell you an obstetrical story from the maternal perspective, because everybody's worried about these babies. And I also, by the end of this lecture, want you to have an idea about the importance of treating women and children history taking. Because even though we see babies that look like this, you need to appreciate that this baby would have a rough trip coming from this kind of pelvis. So in osteopathy, structure and function are related. Thank you. So this pelvis, probably could accommodate everybody. This one might have a struggle with this one. So I want to base a lot of my remarks on treatment of pregnant ladies. However, pregnant ladies aren't just this. They're all of this. I also want you to keep in mind, and those of you have you had an introduction to cranial work just yet? Okay. Well, on my rotations as an OB resident, one of them was anesthesia. And I did that at Washington University in St. Louis. And there was a lovely, not osteopathic, Japanese anesthesiologist who'd come around. He'd say, "We check everybody because you never know who's going to need a C-section and what kind of anesthesia they're going to need." He said, "So I want you to watch me very closely." So as we evaluated ladies for possible anesthesia, because we weren't quite sure yet the method of delivery or the route of delivery, he'd walk in and he'd introduce himself and he'd say, "Open your mouth." Like, wow. And then he'd walk out and he says, oh, spinal. I'm thinking, well, how can you tell that from looking in somebody's mouth? Well, obviously, you're looking at teeth, chipped teeth, so on and so forth. And I said, well, can I do that? Can I go in and just look at people's mouths? He said, well, sure. This is part of being a good anesthesiologist. But what I came to observe at looking at people's mouths is not whether or not the type of anesthesia these people would need, but I'd play a little osteopathic academic exercise and try to determine what kind of pelvis people would have by looking in their mouth. And here's what I want you to think about. If you have a very crooked face, what do you think those ilia do? So if you have maxilla that don't match, what do you think their ilia do? If you have in the palate, you have a high arch on one side and a low on the other, what do you think the pelvic symphysis could look like or be like? So these patterns, these structural patterns are manifest throughout your entire body. And so when you see a head, perhaps that looks like this, then I'm thinking of the pelvic outlet. So when you go on rotations, or have you had an opportunity to examine female patients or to do pap smears or pelvic exams yet? Okay. Well, next time you have this opportunity, you do a bimanual examination, I want you to pay attention when you insert your vaginal hand, the shape of space. What I mean by that, in some ladies, you notice that you want to insert 2 fingers, but there's not a lot of space there, and you find like you want to do this before you do this. Well, because you have to do this rather than do this, what do you think the pubic symphysis arch is? First of all, it's not an arch. It's a straight line, perhaps. Or you do your bimanual exam and you feel like you run right into S2. Very concave sacral base. So you figure out, well, unless this sacrum has some mobility, this head may not get down, the baby's head may not get down into the pelvis. Or you may notice such a nice Roman arch, and that you really almost have to reach up to your elbow to find a sacral base. That's where these pretty little round-headed babies come from. So once again, it's structure and function. And listen to the stories ladies tell you. Everybody who's ever had a baby is a veteran, no matter which way that baby came out, okay? But the veteran stories are unique one to another. You might hear, oh my God, I nearly died. I was in labor for months. I was in labor since the test became positive, it seems. Some ladies will say, I barely got to the hospital. I coughed and the baby fell out. The doctor keeps missing my deliveries. And other ladies will say, it wasn't so bad. I held my breath till the epidural was put in. So the next time, if you see a prima gravida, pay attention when you do the pelvic exam, and you may avoid things like at the last minute, well, we got to do a C-section. Whereas I record my findings and I note there's a very narrow pubic symphysis, very prominent ischial spines, very internally rotated ilia. So I think as osteopathic physicians, we sort of have that little 10-cent opportunity to record these findings and to communicate them, even though we may practice in a group that do not contain lots of osteopathic physicians, and that our colleague will say, oh, okay, I see what you mean. So that you didn't put this lady through extra hours of hell from a mechanical issue that said, you know what, easy out, or, oops, this could be a forceps. And it's not whether this baby is 13 pounds or 4 pounds. So that's another time. Let's have a baby. I want you to understand what it takes from a maternal perspective to do a delivery. Anybody in here parents? Okay. And all of you at some time were babies and were this old. Okay. But let's tell a birth story from this perspective. So educating ladies how to push can be entertaining for us as well as for the patient. So we're going to have a delivery experience. And we're going to do this sort of like wrong way and right way. So what I want you to do is not get so comfortable. I want you to pull your chairs back a little bit, and I want you to cross your knees one over the other, and I want you to wrap your ankles around each other. And I want you to fold your arms over your chest, and I want you to tuck your chin down. I don't want to say fetal position because we're not going there. All right, so I want you to stay all hunkered down and bunched up. Not scared, though. So I want you to take a big breath in, maintain this position, all bunched up. Now, bear down, push that baby out. Okay, don't look up, just push now. Okay, now take another breath in and bear down again. All right. Now I want you to uncross your legs, your arms. I want you to sit on your ischial tuberosities, and I want to take your hands and put them behind your neck and your head. Support your head. Okay, keep your feet both on the floor, legs uncrossed, so you got a good grip of the ground. Take a big breath in. Now push down. Now, you should have a little interaction there with your seat. Okay, so you can actually feel that pelvic diaphragm sort of do something. And the idea that you have your rib cage out of your pelvis, these are the muscles that we want to educate ladies to use when you say push down. All right? Now, I admit that when some of these ladies are flat on their back and their knees are in the air, I don't know where down is. Okay? However, if you could put them in a semi-seated position, and the idea of lifting your arms up, lengthening the thoracic spine, getting your ribs out of your pelvis, then you can actually have the muscles of your pelvic floor doing what they're supposed to do to have a baby. What I see when everybody does this is that people have red eyeballs, they do the salva maneuvers, and they kind of get this grunt thing going on. Okay? Now that's great if babies come out here, but they don't. Or not yet. We haven't figured that out yet. Okay. Okay, I'm technologically challenged. Do I
There's no progressor. Just you have to use either the arrow keys or the space button on the keyboard.
How's that?
That'll work too.
All right, thank you. All right. So here are some indications. I realize you can read these. And because we're in an osteopathic school, here's number 1. And I put this as number 1 because people who haven't been exposed to osteopathic treatment all want to know, is this going to hurt my baby? Well, no, at least that's not our intention. And we'll talk about why that's not our intention and what we're going to do so that's not the undesired outcome to be affected. But there are structural conditions, biomechanical issues that do benefit, okay? And the nice thing about being an osteopathic obstetrician gynecologist is perhaps you've grown up in your practice with your patients. I've had the luxury of seeing female patients when they were in high school, so they're kind of dealing with, I'm thinking about doing something more than just holding hands. So I'm here for a cootie check. Or they're here from, I'm going to the prom, and could you tell me about these condom things, or should I take a pill or whatever? So, you know, you're going to, or, well, my mom thinks I'm X years old and I need a pap smear now. What goes on? What's that all about? But at the same time, you know, you have opportunities to look at structures and sort of do a little forecasting. So the person who has a leg length or a sacral base unleveling, you know, this can maybe give you a clue of how comfortable or not comfortable that pregnancy may be. And with ligamentous laxity, is there still a place in short leg for heel lifts? Yeah, there could be. But you don't sentence somebody to heel lift after the baby comes either. Scoliosis. So, yes, there are scoliotic pregnant people, but in the literature, there's no strong evidence that says scoliotic people do better or worse or have a tendency to more or less cesarean sections. But as an osteopathic person, if we look for muscle and structural balance, hopefully we can make the labor job a little easier on ladies. And then, of course, the postural decompensation. What's that? Well, most people in pregnancy get shorter. They get shorter because they have accentuation of their AP curves. So you're going to get more lumbar lordosis, and then with breast congestion, more kyphosis. And then you kind of do this. But the people without the AP curves kind of do this because they have restrictions at the junctional areas of their spines. So that's part of this postural decompensation. Next is pregnancy-related congestion or edema. So this is the swollen legs, the carpal tunnel issues. Host support. I thought that was kind of classy. They just put that in literature, host, instead of incubator support. And so for host support, these, you know, a lot of ladies will have, for a while in first trimester with increased vascularity and congestion, migraine headaches. And there are some medications that are not in the best interest of pregnant ladies. But there can be related mechanical factors, tension headaches. And if you've got other kids and pregnant, I've never met people who didn't have a tension headache. So let's talk a little bit about back pain in pregnancy. So we talked about the junctional curves, and there can be an increase in radicular symptoms. The two most common ones are going to be sciatica, but could also be piriformis. And in lab, I want to talk about a self-treatment, because by the end of today, you'll get a clearer idea of what do you do with these bubble belly people? How do you evaluate their pelvis? How do you treat them? Because they can't lie prone. So what are we going to do about that? And there aren't enough of us osteopathic obstetricians till you all come join us to fix these problems. So you're going to have some osteopathic secrets later today. Meralgia paresthetica. You know what that is? Chief complaint or presenting complaint of someone who could have meralgia paresthetica in the literature before they talked about pregnant ladies was called the janitor key syndrome, or keys on the belt. Because you'd hook these keys and they would always be around here, around the pocket area. So when patients came in, they'd say, well, I kind of have this numbness or this itchiness or this irritation here. And in pregnancy, as this baby moves out of the pelvis into the abdomen, ladies don't like to wear belts, and they have really saggy, baggy breeches or really loose, elastic type of bands. So they either like to wear them here or like way down here, but nothing that suggests a waistline. Because anything, and even underclothing, it's sort of like the waistline. I call it the underpant line. That on one or other sides gives them some problems. And if you remember, lateral femoral cutaneous nerve, and the most likely somatic dysfunction is going to be found where? Board question. A little lower. Could be L1, 2, or L2, 3. Yeah. Yeah, you get 2 extra points. I'll write to NBOME at the end of the day. That's where I spent my weekend. And then, of course, nocturnal hypoxia. Pregnant ladies can be challenged. If they were stomach sleepers before being pregnant, and now you have to be a back sleeper or a side sleeper, that's a problem. Or if any of you have accompanied a pregnant person for ultrasound, they can't tolerate lying on the ultrasound table too long. They feel nauseated because of compression of the vena cava. So they may get nauseated, they may have headaches, they may have shortness of breath. Well, you just don't change in your pelvis when you're a pregnant person, but there's some interesting rib cage changes. And I put this information here, and I put an anatomical picture here. You know, I personally don't put a lot of anatomical pictures, and when I go to convocation in places, I still have post-traumatic stress. And I hallucinate the formaldehyde and some of the odors. So I'm kind of up here thinking I have to get away from this slide because I get olfactory hallucinations. But what I would like you to appreciate is the design, the muscular and ligamentous design. You know, this looks like a basket weave here. And look at this. Look at the directions of these muscles. All around the xiphoid process, the sternum. And then look at the direction of the thoracolumbar fascias. You got a little hatching here. So your rib cage, interestingly enough, throughout pregnancy, the circumference is going to increase. The subcostal angle increases. That's pretty dramatic. 68 to 103 degrees and 2 extra centimeters. You know, sometimes when you're in the labor room, you're praying for 2 extra centimeters for that baby's head to fit through. But when it comes to just breathing, the work of breathing and helping the heart to pump efficiently is under the influence of good muscle function. And this muscle function and respiration, the effort of breathing changes as early as just finding out you're pregnant, to getting through the first trimester and you have an ultrasound showing you have a viable fetus. So this isn't like you don't wake up at 7 months pregnant and decide it's kind of tough to breathe. And then you have perhaps superimposed lung disease, asthma, people who still smoke, some COPD issues, and then the age of the patient. You know, I used to take offense at elderly prima gravidas being 30. But we now assist with reproductive technology ladies who are in their middle to late 40s pregnant for the first time. Think about that. And so when you take care of patients who are pregnant for the first time at age 12, their tissues have a certain type of texture and flexibility than when you're in your later teens, your 20s, your 30s, and now your late 40s. So, yeah, I guess you are a geriatric first-time pregnant person after age 35. So, yes, there are mechanical effects and there are hormonal effects to explain respiratory changes and respiratory function, predominantly progesterone and relaxin. All right, so mechanical stresses once again. We'll cover those. And this is in the literature, current literature. Excuse me. Lumbar lordosis increases in 85%. Pardon me. I bet you got that on tape. What about the other folks that it doesn't, increase? These people never had a lumbar lordosis to speak of to begin with. And these are the people who may be prone to backache, but more of a front of the backache versus the lumbar lordotic person. So that's my next trick. Do we have someone in this room who could be or could not be pregnant but has lumbar lordosis? We'll take anybody. Come on down. Thank you. I just need to cough more. You mind standing right here?
Okay.
Thank you. All right, we'll do this on both sides. So first, would you face this direction? It's kind of nice. She's got a little tie, but it's a little too high. But can you appreciate somewhat of a lumbar lordosis here? It's not so super duper, but do you tend to get sort of like backache, heaviness in this area? Mm-hmm. And maybe fullness in the top of your legs?
Oh, yeah.
Oh, yeah. And this is baby number?
2.
Okay.
Mm-hmm.
Did you have this with baby number 1 as well?
Not so much.
Understood. So I have devised what I call the osteopathic butt belt. I just didn't bring it.
Mm-hmm.
So the idea is, pardon me, what you'll see in catalogs and magazines is they call it like the prenatal cradle and SI belts. They're stupid.
Mm-hmm.
Okay, they're not osteopathic because they scrunch here, they're way up here at the top of the ilia, and they're at the upper pole of the SI, but that's probably not where your problem is. Because in pregnancy, this whole pelvic bowl tends to tilt forward. Lumbar lordosis increases, and you might find yourself as this baby gets bigger is that you're trying to figure out where in your foot you want to stand. And then if you breastfeed, then these shoulders tend to roll. So, this tilts forward, you're leaning backwards, and this head probably is back and forth like a pigeon.
Mm-hmm.
Okay? And if you have facet asymmetry, then you kind of walk like a combo chicken pigeon. Because you shift from side to side while you're doing this.
Mm-hmm.
Okay? And if you've got twins or multiples, that gets a little more dramatic. Next thing that happens, because you're staying in this position, you probably have lower leg pain. Now your feet may or may not hurt, or you may feel that your feet are spreading out like a duck, but you tend to hyperextend the knees. So I have just the thing for you.
Okay.
Butt belt. I have a sheet, but I usually recommend people go to Salvation Army and get a pair of jeans, denims, cut the pant leg, and make something that's about 4 inches thick. Okay? And what we're going to do is, rather than make this an SI belt, we're going to go to the trochanter. So you need to help me find, there we go. Around the S2, pubic symphysis. So why don't you do that? Why don't you put one hand pubic symphysis,
Okay.
and the other one up here at the natal cleft. Now, do you see that her back hand is higher than her front hand? Okay. Can you turn this way so these audience members can see this? Can you appreciate that? Okay, we're going to do a little dance and hope you don't mind. Okay. Let's come all the way around.
Mm-hmm.
Okay, cool. Now, I want you to watch this because we're going to compress her trochanters, and we'll see if we can minimize. So keep your hands there so you can see how this is going to change. Don't make a fool out of me. Separate your feet a little bit. There. Feel that change?
Mm-hmm.
See your hands change? Not a lot, but they change some. Now, hopefully that feels a little more comfortable.
It does, yeah.
Should I put the microphone up closer? Did you hear that? It does. It does. Okay? Now, look straight ahead. I want you to feel this, and doctors, I want you to see this. See how she has this little shimmy thing going on? Can you feel the difference, the before and after difference?
Yeah.
So here we reduce the lordosis. You want to turn around this way? Tighter the better.
Mm-hmm.
Okay, then we let go. Okay, and this is your 50-cent treatment.
Nice.
Yes. You can have a seat there for a minute if you like. So the mechanics that I wanted to point out are the following. The sacrum sort of is a triangle, right? And the ilia, when they come together to articulate with the sacrum, triangle and a triangle. So what happens? If this bowl tilts, it could lock up upper pole or lower pole of the SI. If there's a history of fall on one's butt, there could be a little dislodging of the sacrum, usually posteriorly. So the ilia that used to do this, now do this. And that sacrum slides down. Then ladies will complain of urinary dribbling, with or without coughing. Or they'll say, this baby is just right here. Although we see it's higher, but all the complaints are down here. Then you get ligamentous laxity, the psoas comes into play. So that's where this comes from. So after treating the pelvis, I recommend this belt because you put the sacrum back home, so it's not like a shirt hanging on a clothesline. Put that sacrum back home, restore the relationship of the SI joints bilaterally, and then by sort of like putting a sash at the level of the trochanters, you're also stabilizing the pubic symphysis. I didn't take away that lumbar lordosis, but what I did was put that pelvic bowl, I untipped it, if you will. Made it go back to looking like a bowl rather than a pitcher that's pouring something. And as you do this, this baby will move up. It's easier to walk. And this is positioned in such a way that people will worry, like, is this going to bother or hurt my baby? No, it gives you pubic symphysis support. I also recommend this for ladies who've had gynecologic surgery, or they had vaginal prolapse surgery, wherein they have this persistent lumbar lordosis problem. And I think it would be useful if you have a urology rotation, not only to review that anatomy, but you know the big money is in doing procedures. So they do silicone injections, they do transvaginal tape, urethral suspensions, they tack up that bladder. So architecturally that looks good and sounds good, but when the patient stands up, she still has this. So even though you fixed that urethra and you pegged it back up, you got the rest of the bladder and you have the bony structure of the pelvis that hadn't been addressed. And if you got a short leg, then you got a rotation. That's all there. Those are all, I'd like to say, pre-existing somatic dysfunctions. So if you're going to take care of somebody, take care of somebody. Somebody, not just some urethra, some bladder, some short leg. So if you have opportunities, avail yourself to those opportunities to take a look and think about, you know, you're putting a little suture here and there, but what about the rest of the owner and the rest of the parts? And so by, again, addressing with retilting the pelvic bowl, you're decongesting the vascularity of pelvic organs. Okay, here's something else to think about when you do your pelvic exams. The ladies who have pelvic pain and they're frustrated because there's no infection, the ultrasound was normal, no cyst, or there's a follicle cyst, which are normal. These are all normal. Why do I hurt? Well, I don't know how something here is up here. You know, I'm going to get this, well, it's all right here. No, it's right here. It's right here, doctor. And people keep getting frustrated. And there's no prolapse. You don't need a pessary. And maybe that's when people think, I want to tack this up or I want this or that. Well, here's what I want to suggest to you as an osteopathic physician. In your undergraduate years, you are going to be taught sacral diagnosis, how to fix an ilium, how to fix a pubic symphysis, how to deal with leg length discrepancy, how to deal with lateral curve secondary to muscle imbalances. But when you do your pelvic exams, feel the laxity of the ligaments of the cervix at 3 and 9 o'clock position. Feel for that gritty texture of endometriosis, the uterosacral ligaments, but see how much that cervix moves or doesn't move, and then I call it catch. Catch that fundus and that cervix between your hands, and when you move that uterus back to the midline where they usually live, they can tilt forward or backward. That's not a big deal, but they're not usually twisted. They're not usually learnt to one side. So either because of mechanical injury or maybe surgery for removing a cyst or an ovary in ectopic pregnancy, I don't see many people who go back and make sure everything's back home. You can do that with your 10 fingers. And you know what? The ultrasound isn't going to change. But people get up and you say, when everything lives where it's supposed to, it doesn't hurt. So think about that sometime. Still okay there? See what else we got to cover. Is this making sense? I know you're probably sitting there like, wow, I never heard that before. Yeah, I know. It took me 30 years to hear it. There you are. I respectfully call this the space-occupying lesion. So realize when you have a lordotic area here, think of sympathetics, think of the tug, think of the genitofemoral nerves. So that's part of the waistline issues people talk about. So sort of like these vague, I don't feel right or this is bothersome. Here are places along the spine to look. And as this baby descends, okay, and depending on how active or not active ladies are, hemorrhoids live here. I call these varicose veins of the rectum. So you want to make sure this baby's happy so that there's good drainage. And then you also want to make sure this baby's midline so there's equal distribution on the bladder. And then again, the tilt of the pelvic bowl. So this bladder isn't going to leak so much. This looks pretty physiologically balanced. So what are we looking for? Shortened segmental muscles. Here, we're looking for facet issues. And again, if you're pregnant at 40, you could have some arthritis here. That just isn't going to be happy during your pregnancy. So you can have overstretched abdominal muscles and psoas muscles. Let's see if I have another picture I want to point out. Well, you know that. You know that. Here we are, front view of the space-occupying lesion. So some other benefits of things you can do with your 10 fingers, osteopathic treatment-wise. See, round ligament here. Where does this attach? Pubic symphysis. Now, as someone who, I think in a previous life, it's karmic payback time. I was an OM fellow, and I used to laugh at all my instructors and think, you gotta be kidding me. Do what? So here I am, instructing first and second year students. But I feel really happy I'm in a place that when people come in, they say, do you mind if we take our clothes off while we do this? I said, well, within limits. Whereas in Kirksville, people are grabbing their belt buckles, praying that, oh God, I'm not going to that lecture. Point being that you are remiss if you do not examine this part of the pelvis. You can get somebody's butt on straight, you can get their legs length equal, but you really have to see what's up with pubic symphysis because of visceral and organic attachments. So you've only done less than 50% of your job if you neglect this area. Furthermore, ladies will have a backache, you've done everything you could, and you maybe in your clinics have had the experience of people saying, well, they couldn't do this before they came in, right? So here they are doing it after treatment. But, it still hurts right here. And you examine right here, and you don't find anything right here. Well, because right around here, which closely correlate to areas of anterior counterstrain points in the neighborhood of L5. But when you're looking for these counterstrain points, as I do, they'll say, oh, that's it. I'm like, wow, it's the point. They say, no, that's my back pain. So very often, in palpating around here, looking at these ligaments, broad ligaments, inguinal ligaments, they all can potentially refer pain to the mostly upper poles of the SI joint. So it's another place to look for trouble, doctors. Don't let that go away. I also find it's interesting, and I hope other people, I don't have enough numbers yet, but out of my private practice, I used to make notations, kind of think, well, isn't this kind of interesting? But I would like to talk to residents because this circle is where you would hear fetal heart rate. Okay, the heart is closer to this structure than it is to this structure. And so if you hear a heartbeat below the umbilicus after 7th or 8th month, then it's probably a vertex or head first baby. Yippee. Because if it's a breech, well, maybe you have to make alternate plans, like heal with steel. And I've observed in my practice that I more often than not am able to auscultate heart tones on the short leg side. So I just invite anybody who's going to be a resident is start making your track record, and if enough of us do this, there's something to publish. And this could either be because of a functional leg length, it could be due to a scoliotic leg length, not an idiopathic or congenital, but it just has always been interesting to me that I hear this on the short leg side. I don't hear them on long leg sides. And twins, well, they could be anywhere, as you know. Relaxin in pregnancy. A lot of you might have heard, oh my goodness, don't ever do high velocity to pregnant people. Don't crunch them, don't roll them. Well, I usually say, yeah, to first and second year students, yeah, I'm right with you. Don't. Don't because you don't have the experience. Don't because you need more track record in palpation and just being able to appreciate balance of tension. So for those folks who think this ligamentous tension stuff is foo-foo, transfer to an MD school now. Don't wait. Don't wait, because even if you're going to do surgery, you still have to appreciate, even if it's robotic surgery, how carefully are you going to use that harmonic scalpel? Where are you going to put these clamps? How far is this blood vessel from this nerve? So you're still looking at tensile strength. Even if you're going to suspend a bladder in somebody's pelvis, you still need to appreciate that, only with instruments. Here, we do it with our hands. Then maybe someday we'll do it with instruments too. But the point I want to make is, you know, it takes the same palpatory skill to do an excellent cranial treatment, muscle energy treatment, high velocity treatment, counterstrain treatment. Because that whole time you are reading changes of tension and appreciating balance, not balance. Then you incorporate respiration from your patients. So you're incorporating all these factors, but your first focus is, does it move? Where does it move? How much does it move? What do I need to do to make it move? And how much is inherent? How much does the patient already do or not do to make something move? So when you get down the road, I'd say, yeah, high velocity could be okay if you have some experience. Now, I suspect some people are worried who may not have this experience, are worried about ligamentous laxity, but what's responsible is relaxin, all right? But in looking at the literature, they're all worried about people putting them into labor. You could put somebody in labor with soft tissue if you want to. But look, relaxin's the highest level it's ever going to be in the first trimester. All right? They use the relaxin argument saying, wow, that's going to pull your pubic symphysis. That's that silly millimeter for the baby to come through. Well, you know, it's been there a long time. And in fact, in literature, there are studies in obese ladies. And I had some obese ladies that were pregnant. They were scared to death because they had low back pain. They had musculoskeletal pain. And, you know, it took them a long time to get pregnant, probably because associated diabetes or sugar metabolism issues. Okay, so here we are, the grand prize. I'm pregnant, but I don't know if I can survive this pregnancy, doctor. My back hurts so bad. And there might be some of these people that OMT might not 98% address their pain. I've actually had people consult and say, do you think I should not continue this pregnancy because it's so painful. I have such bad back pain. You're going to hear all kinds of stuff. And I'm thinking, well, why is that? Well, relaxin. I tell them they'll grow out of it. That's not a good word. I mean, the baby will grow out of it. So we're hoping for this rather than this. Okay, but that happens too because I know pregnant, pizza, princess, they all kind of begin with P. So I understand that. And then again, if you've had your women's health course, here's background information. Where does that relaxin come from? Okay, but it continues throughout pregnancy. It goes down a little bit, but it comes right back to soften up and stretch that pubic symphysis in labor. So there's your scientific explanation. Now let's talk about progesterone. Y'all know about estrogen. You need that to get pregnant. You need that to have menstrual cycles. But what does progesterone do? Well, in the literature, progesterone has been shown to, sort of cut off uterine irritability that could progress to preterm labor. So instead of giving everybody magnesium and secondarily treating their blood pressure, some people think, oh, well, let's do some progesterone. But you want some smooth muscle relaxation just to give that baby room to grow. And you want some vasodilation just to have circulation, not just umbilical, but you want to give nutrition to the uterus as an organ to support the growth of the fetus. But what's the not so good thing? Slowed gastrointestinal motility. So these are the ladies that say, when I'm 7 months or 8 months, I eat, and my lunch stays here for 3 days. So pizza may not be such a great thing. And then hydroureter influences a greater presence of hydroureter. Well, what's really good about that? Not too much. What makes it worse? Well, in Kirksville, Mountain Dew is like the beverage of choice. And so there are a lot of pregnant ladies with kidney stones in Kirksville. And now everybody's in on it. Pepsi will give you those stones. Coca-Cola will give you those stones. And so for pregnant folks with hydroureter, it's more back pain from kidney stones. And a greater opportunity for urinary tract infection as well. And furthermore, progesterone also contributes to ligamentous laxity. So once again, hip pain, pelvic joint pain, of course, which is treatable by you and educating your patients for self-treatment. Now, what other potential bad side? Fluid retention. So pelvic congestion and swelling of the legs, which may or may not be related to a blood pressure issue. If that's for me and I won, let me know. All right, some more features of why we treat osteopathically. Well, we can't always avert hormone effects, but we can modify them. The valveless circulation to the central nervous system and the spine. So ladies in the upright position or gravity, it's not like going to a salmon fishery watching circulation jump up a ladder of your spinal cord, all right? But when you have someone lying down, and if you're just springing, and if you notice a restricted segment, and you elevate it with the patient in position, I'm listening carefully for, depending on the level of the spine, oh, my legs feel really warm. Not numb, that's something else. Warm. Upper extremities warm. Okay? You can correlate those with areas of somatic dysfunction that could be treated, and they're usually single segment issues as opposed to a group. So sometimes that's my quick and dirty scan. If someone's lying down or seated in a chair with a back and a support, I just kind of use my fingers to bounce off those spinous processes. Something feels restricted, I push a little more anteriorly. Oh, I feel warm. Maybe tingly, but I'm listening for warm. So it shows that there's something going on with circulation. Fix that spot. Because pregnant ladies don't want to do this and all the other types of tests and screening things you've learned in lab. Pregnant ladies don't like to do that. They're tired. So they don't mind lying down. And after you listen for heart tones, just do the little finger dance, I call it. Okay? We talked about posture. We talked about just lying down on your vena cava and those fascial tensions. First trimester. Well, here's what your focus should be. History and physical, previous pregnancies, what happened to them, full term, short term. So that'll tell you what's going on. Maybe that uterus doesn't like being pregnant for all 9 months. It might just kind of shorten the time span, and babies are born at 36 weeks or 34 weeks. Also recall that when we have these menstrual calendars, they're based on the national average, which is 28 days. Every 28 days someone has a period. I don't think the ladies in this room have clock-white periods. Some say, well, I have one every 35 days, every 32 days. Sometimes they're 28, and then there's another month there's 30. So if people say, oh, my babies are always 2 weeks after the due date, probably because they had 32 or 35-day menstrual cycles. Okay? Isn't that what ultrasound's for? So I hear. And then you're going to look at risk factors: occupational, environmental, home, social, emotional, and then your structural problems. So somebody who's scoliotic, they're going to have maybe complaints of aches and pains that other people might worry about, but you're not, because you know who this is. And there's various things you can do for your patient and to your patient. All right? Rapport and begin counseling. You know, I probably better remove that because in this day and age, people look at obstetrics as a job and not a profession. You clock in, you clock out. Done at 5. I'm not answering the phone. So, again, that depends who you are and what your practice is going to be when you're finished. So if you're used to working in a group of 2, that's great. If you work in a group of 10 and you ask the pregnant lady, who's your doctor? She says, well, I don't know. It's these 10 names. So something else to think about. So how do you establish rapport? Or maybe you're going to practice in locations where you're it, tag you're it, and you're never going to leave town for the next 50 years because ain't nobody to cover you. Chapman's reflex. I want to talk a little bit in lab today about how to do a Chapman's treatment, but I want to call to your attention specific locations that patients may have complaints. They may have organ complaints like urinary pressure, or they may have vague abdominal complaints, and you're worried about, as you should be, an ectopic pregnancy assist. And so what I'm suggesting to you is when you do your appropriate technological evaluation, but it's still there, doctor, I recommend that you look here. Okay? These are ovarian points, and up till about the first 16 weeks of pregnancy, one or other ovary takes on the job of nourishing that fetus till the placenta is formed and kicked in and working. And then I look around the umbilical area, and these are all urinary points. So people have nausea and vomiting, but then they'll tell you something silly like, man, I could eat anything, and they do. And they do, but oh, I just have this weird tummy feeling, or I'm kind of nauseated, but I don't vomit. And you get a urine dipstick in your office, and you might see leukocytes or leukocyte esterase. And, well, you're going to culture, not culture, or what's going on? I check these Chapman points. The ones who have belly pain, drink a lot of Mountain Dew, hydroureter, I'm looking for stones. So I'm looking umbilicus, so over an inch, up an inch. I'm looking at kidney and ureter function. So these are kind of little handy-dandy while you're waiting for the lab work to come back. While this very anxious prima gravis says, what do you think it is, doctor? What are we going to do? Second trimester, here's what you're going to be addressing, and we're going to take care of the lab, show you how to treat round ligament pain. Carpal tunnel is very common because the brachial plexus is going to be squished from anteriorly rounded arms. Third trimester, here's where the swelling comes. Now around 28 weeks is magic. It's magic to be very careful. If you see a sudden rise in blood pressure, start thinking about preeclampsia or hypertension in pregnancy. So there could be another reason why those legs are swelling, or it could be just plain old mechanical, which is the mass effect of the uterus in the pelvic bowl. Okay? And every now and then lymphatic treatment is nice, and I want to show you a variation on themes of lymphatic treatments, not just pumping people's feet. Now we're going to treat the diaphragm today. Labor and delivery. You know that. I want to say a word about epidurals. Have you had an epidural?
No.
You bit bullets?
What's that?
You bit the bullet?
Well, I used hypnosis.
All right. I remember a divorce proceeding taking place in a labor room because this lady decided to do Lamaze, and you sort of like do this visualization. And she said, could you get him out of here? I said, why do you want me to get your husband out here? She says, well, you know you're supposed to focus on something. My boyfriend was better looking. I said, oh, do you have his picture? She says, well, I said, I'll just step out. I'll keep everybody out for 5 or 10 minutes, and then we'll come back and hunker down. We'll put the dog picture back up. And then I'd hold push toward the dog. And she says, well, how about the other picture? I said, whatever. So you too will have these experiences in your practice. I just felt I could repeat this story. All right, so sacral base is going to be anterior. It's going to start anterior because of the fetal effect. As this baby moves down into the pelvis, approaches the ischial spines, it's going to move anterior. With the amount of pushing, the type of delivery, it could lock posteriorly. So when you see these funny sacral things, you think about mechanism of labor and delivery. Epidural, as I was beginning to speak about. What happens when we do an epidural? Why don't you face forward a second?
Sitting here?
Yeah, that's great.
Okay.
So what happens, just look at it this way. So you're lying down. Or sometimes we do epidurals sitting up. So what do we ask people to do? To tuck your tummy in. So we ask you to stick your stomach in. That's right. So she rolls and she bows her spine toward the anesthesiologist. And then they prep and they say, okay, you're going to feel a little bee sting. What happens? Whoop. Right? So you're doing this, you're here, and even if they're laying on the side and you're all tucked in, they say, little pinch, little stick. Now instead of doing this, they go, if you're on service, watch what level that needle goes in, because that's going to be the extended spinal segment. That's going to be very nice to treat with muscle energy as soon as that baby comes. Because that's why people come up with this, oh my God, I have epidural, I thought I was going to go blind, I thought I was going to paralyze. I mean, you hear all these really nasty things about epidurals, or, oh, I've had this backache ever since. And I thought, man, how crazy is that? Until I looked at people's backs, and as I poked, she said, you know what? I forgot to tell you, that's where they put the epidural in. Oh. And that's the very posterior L3, L2 segment, the single segment. Those single segments in lumbar spine are boogers because most of the time they're group dysfunctions, as you know, from scoliosis or from gait issues. So keep that in the memory bank when someone has a complaint. Ischiorectal fossa, we'll talk about that in the lab. You know, this is really important. This is another thing that people tee-hee and giggle about, but this makes the difference, I think. Well, I believe, not I think, I believe. I think and I believe that ladies who have had challenging episiotomies, I call it sort of like bony butt disease. Oh, doctor, it hurts to sit down and say, yeah, we lost weight, you got a bony butt. And you're like, well, I don't think so. Not that bony of a butt. And so they'll still have persistent incontinence, or they'll just feel pressure with coughing and walking and so forth. So I want to talk about the importance of treating the pelvic diaphragm in this area. So we'll come back. You're not off the hook. Axillary pump. Again, I want to talk about the opportunity to, with your 10 fingers, relieve mastitis and congestion. And you also secondary relieve any type of trauma to the brachial plexus in this area. Okay? However, this is a secondary treatment. The primary treatment should be from about T1 to T5 or 6. Okay? That's somatic dysfunction area for breast as an organ, a viscera, and also for lungs, because we talked about the diaphragm. And ladies, when they nurse, tend to do this. They lean forward. They're picking up other kids. They're leaning into the baby bed. So we are going to talk about treating this area. And also, when you've been learning about reducing edema, you talk about treating the root of the neck, right? Yeah? Are you guys under Mountain Dew or under coffee? Or I live in Washington now, so it's all about Seattle's best. It's also about Wine Valley. Happy hour starts at 10:30 every day. The bad news is I have to start at 8. So there is sort of a pump technique we're going to talk about at the sternoclavicular area that will get fluids going. And even though this is for maternity or pregnant ladies, I also use this in ladies with breast cancer. So I don't have another opportunity today to talk about gynecology things. I'll come back to this. Let's see what else we have here. Oh, let's talk about, well, you know about the considerations, and here are the caveats. Let's talk about the don't you evers. And don't you evers treat people unless you know why somebody who's pregnant is bleeding. Why are they bleeding? You know, you could have a vulvar varicose vein, okay? But if you don't know that, and you think somebody's having a threatened pregnancy termination, then you better figure out what's going on. Don't go in there and fish around with those sympathetics. If someone has unstable vital signs, so they're in labor, and you've heard in literature, you know what, kind of miserable, I'll do a CV4. Well, let me tell you something. If somebody's in the throes of labor and you're that miserable, do you really think that patient's going to lie down so you can compress their fourth ventricle? I don't think so. Okay? It might bite you. If somebody's in preterm labor, you better figure out first why they're in preterm labor before you're turning it off. You might have ruptured membranes. Maybe it's just that baby's time to be here. So don't go messing around with that nervous system. You got to get some more information here. I say this because personally in my practice, I had a student on rotation. A lady came with a complaint of backache at 29 weeks, and I don't take phone calls unless it's another doctor. I usually say, please wait, but Dr. So-and-so. So I said, I'll be right back. Just get some history. I left. I came back. This lady was really crying, and there was a wet spot on my table. I said, what did you do? He said, I fixed it. I said, what did you do? He treated her thoracolumbar junction. She ruptured her membranes, and we had a baby an hour and a half later. And that took 7 years for that case to get dismissed. Yeah, so I thought I'd share. And it was just, well, I don't really think I did anything. Yeah. I don't know where this person's practicing, but I'll send you information. You could be on the lookout. Okay, placental abruption. So clearly there's a very irritable uterus, and that placenta's pulling away. I don't think there's anything 10-finger you can do except head to the operating room. Okay, ectopic pregnancy. Woo! You got something bleeding going on there. You got diaphragm irritation. I'm sure not worried about C3, 4, and 5, okay? I'm worried about intubating, okay? We'll do that C3, 4, 5 thing later. And premature rupture of the membranes. If these membranes are already ruptured, you got to rule out infection. What's the source and the nature of that irritability, okay? So I call these pretty much absolute contraindications. I see what time it is. Any questions? I know I had an exercise here we'll do in lab.